Warm good afternoon everyone. I am Dr. Prawesh, currently a third year junior resident in the Department of Internal Medicine in BBKHS. And I will be presenting a case of unusual journey which we see regularly in our OPD basis as well. A case which was initially diagnosed and treated as a case of subclinical hypothyroidism, and which on follow-up which led to a grave diagnosis of TSHoma, or TSH secreting pituitary tumor finally. So it is a TSHoma masquerading as a subclinical hypothyroidism, a diagnostic cause. And I would like to thank my moderator, Professor Dr. Robin Masquerading, for guiding me through this presentation. Coming to the setup, it was a young gentleman of 36 years age who presented to our OPD with a vague complaint of generalized fatigability and generalized weakness and fatigability for 5 months. There was a long history, and we in OPD basis wise we took a short history and sent relevant investigations initially. And however, the negatives, there was no heat or cold intolerance, there was no history of weight loss or any palpitations, no history of tremors or anxiety or panic attacks in between. Next, this was the admission was done later on. The patient was sent to home with some investigations that we did initially, and on looking upon the results, we saw that only the abnormality that was present in our reports where the elevation of TSH level was seen with a high normal of FT4 and FT3 was in the normal range. And suspecting the increased level of TSH, we started the patient on 50 microgram of thyroid, that is levothyroxine was started, and patient was kept on follow-up. However, initially we can see that in the month of January, his TSH was 17, however the FT3 was upper range of normal and FT3 was also normal. We started him on 50 micrograms of levothyroxine, and we followed up for a month how would the patient receive the treatment medication, and we also repeated it after a month where we can see still the TSH level was static, whereas the value of FT4 was risen significantly more than that of normal, which was a paradoxical thing because after giving the exogenous thyroid hormone, we physiologically need to see that the TSH should have been suppressed by now and the T4 level should have been normal. So this result that we found in this patient led us to think about, is there something that we are missing, or is there any other diagnosis that we might have been missed in his OPD basis. So the patient was admitted, and we did a thorough examination of the patient. And the positive finding we found out in the initial admission was only there was a butterfly-shaped mass moving with swelling, and it was grade 1A, that is not visible, however palpable while the neck is extended. And on CNS examination also, there were no any abnormalities that were detected at the time. Now next, we after looking at this investigation, we did a thyroid USG of thyroid as well. There was slight enlargement of thyroid gland, however no significant abnormalities or mass-like lesion. Only a grade T-types 1 and 2 lesions were present in the USG of the neck. Now the main diagnostic challenges started. That is common causes of high TSS, that is lab interference, non-compliance to medication, and thyroid hormone resistance syndromes. And there was also a clue that pointed us to the secondary diagnosis, that is the paradoxical elevation of T3 and T4 with rising TSS. Next, we did the hormonal panel suspecting underlying central cause of elevation of the TSS level, where we can see there was slight elevation of prolactin level more than normal, and IGF was also done later on, which also shows upward of normal in a patient that is age of 36. It was slightly high in the higher range. However, other hormonal factors were normal. So next, we suspected that the link between the thyroid elevation is related to the central cause, that is pluri-hormonal involvement strongly suggested the central structural reason, and we proceeded to do MRI. And we ruled out the other interference and primary hypothyroidism as well. Now we did the X-ray. I already told only terax 1 and 2 was found, and we did the MRI of the brain, which showed a large mass-like lesion present in the, that is 2.2 by 1.5 by 1.7 centimeters cellular supracellular solid mass lesion causing cellular expansion and thinning the cellular floor as well. And there was a bilateral cavernous sinus extension as well. And this made us the diagnosis of supracellular mass that might be a pituitary macroadenoma given the size of greater than 1 centimeter. Then we also did a 99 patient was there before to the other center for doing these investigations, and we showed the 99 potentium scan showed the enlarged thyroid gland with increased tapping function in both the lobes, which generally shows the TSH dependent increase in size and function of the thyroid gland as well, which further increased our suspicion towards the primary problem being the TSH secreting tumor, despite the resistance condition. Now, the definitive diagnosis was made, the TSH secreting pituitary adenoma, that is TSHoma. And later on, patient further went to do surgery in Chandigarh, where the transsphenoidal surgery of the mass was removed, and after the surgery we can see that the TSH was rising in the first with FT4 also elevated. However, after the surgery we can see the rapid decrease in TSH level, and FT4 also normalized. So the diagnosis, retrospective diagnosis was also correct at the time. So coming to the significance of the case, we have seen the cases of macroadenoma of pituitary previously as well. However, the tumors that secretes the TSH is very rare to found, with the literature showing 0.3 to 2%, and some are up to 3% of macroadenoma secreting the TSH was also seen. And after looking at the retrospective way, the tumor also secreted not only TSH but also small amount of growth hormone, which can be seen by somewhat increase in the IGF-1 level, as well as the prolactin level was also upward of normal levels. So the picture filled into the place that it is a TSH secreting tumor as well. And later on it was also confirmed by the biopsy as well. So the tumor means there is autonomous TSH secretion, there is massive TSH output, and the thyroid being normal, it will secrete the T3 and T4 level. However, the barrier will be broken there because the negative feedback loop, which generally suppresses the TSH, is absent due to the autonomous secretion of, by the TSHoma. So this cycle is continued, and it might lead to the hyperthyroid or thyrotoxic state as well. So the key takeaways is uncommon presentation is of elevation of TSH despite the adequate thyroid hormone replacement, and the stepwise evaluation including hormonal assays and imaging is critical for the identification of the underlying